Thank you for joining the HIV Grand Rounds today. We'll be getting started in a few seconds. My name is Damilola Jalayemi. I'm with the UCLA Center for HIV Identification, Prevention, and Treatment Services. I'm going to do a brief overview of what the HIV Grand Rounds are, and then I'll hand over to our moderator to go ahead and introduce our speaker. The HIV Grand Rounds series is offered by UCLA Center for HIV Identification, Prevention, Treatment Services, and the UCLA-CDU CFAR. And it consists of hour-long lunchtime lectures that are delivered by invited guests or distinguished members of the UCLA faculty. The aims of the Grand Rounds series are to share the latest research findings on HIV prevention, care, and treatment, and to highlight important developments in HIV-related research. It's also to encourage scientific collaborations and networking, and to excite an interest in HIV research for early career investigators and provide resources about new findings, fundings, and career opportunities. So thank you for attending our August HIV Grand Rounds series. We're going to go ahead and get started now. I would invite our moderator, Dr. Scott Comilada, who is the director of Semel Institute's Center for Community Health, and also faculty at the Center for HIV Identification, Prevention, and Treatment Services. Dr. Comilada, go ahead and join us and introduce our speaker today. Thank you.
Thanks, Dami. Hello, everybody. Really gives me great pleasure to introduce today's speaker. Dr. Dallas Swendeman is a behavioral and prevention scientist. He co-directs the Semel Institute Center for Community Health along with myself. He's a CHIPTS Development Corps co-director, and he also co-directs the Center for Gender and Health Justice at the UC Global Health Institute. His work specializes in mobile technologies for prevention, self-management, and treatment adherence for various health conditions, including HIV/AIDS, substance use, mental health. His expertise includes research on youth living with HIV and national scale interventions developed with the CDC's DEBI programs, such as the CLEAR intervention. He leads groundbreaking work. He was principal investigator on the NICHD-funded Adolescent HIV Medicine Trials Network project that he's going to present today. His contributions also span work with HRSA, SPINS, the TAPIN projects, providing technical assistance on the development and evaluation of mobile and social media technologies to enhance HIV care management and engagement. His holistic approach embraces a range of prevention and intervention approaches, including community partnership research on structural interventions with sex workers in India, shopping mall-based family wellness centers, and empowerment programs in South African townships with international collaborations in India and Cambodia. Dr. Swendeman's impact is far-reaching, epitomizing his commitment to pioneering technology-enabled solutions for diverse health challenges. I have to say, you know, the best thing about Dallas, I've known him 20 plus years now, which really spans his career for most of it. I've gotten to know him, and besides what I've read here and leading studies with long names and acronyms, I just got to say, I'm always impressed with his passion to address health disparities in his research. He and his wife are great, well-rounded people. If you don't know, he really shreds on the guitar, and his wife is quite a chef. And I guess we must think alike because it looks like we're wearing matching shirts, and we didn't actually plan that out. So without further ado, Dallas, I'm going to turn it over to you. Looking forward to the talk.
All right. Thank you so much, Scott. Really appreciate it. And thank you, everyone, for coming today. And taking some time to learn about what we did on the ATN 149. So I'll be talking about optimizing PrEP uptake among youth in Los Angeles and New Orleans via telehealth coaching, online peer support, and automated texting. These are the results from the Adolescent HIV Medicine Trials Network Protocol 149 that I was the protocol chair for. Let me see here. Here we go. Okay, so acknowledgements and disclosures. Research was funded by NICHD to a grant for multiple PIs of Mary Jane Rothram, Isa Fernandez, and myself. The content is solely our responsibility and does not represent the views of the National Institutes of Health, and we declare no conflicts of interest, financial or other. I'm going to give some background start on HIV and PrEP among youth and young adults. I'm going to kind of lightning through a lot of these. These are CDC slides, but just to provide some background. So there are disparities in HIV diagnoses, and more than half of new HIV diagnoses are among young people. And even though the majority are among the 25 to 34 range, many of those folks acquired HIV when they were under age 25. Of course, gay, bisexual, and other men who have sex with men have the highest proportion of new incident infections, but not solely. And there's quite a diverse group of people at risk. Of course, there are also racial and ethnic disparities that persist, particularly for African American or Black folks in the United States. And these disparities are even more pronounced for youth ages 13 to 24 years old, where we see almost 60% of new diagnoses among Black and African American youth, compared to about 40% for the national averages. Now, in terms of PrEP, there are also disparities in PrEP coverage in the United States. So overall, we're all working to improve PrEP coverage. 23% of the people who could benefit from PrEP prescribed in 2019. Those numbers have increased, but those are recent CDC data. But youth ages 16 to 24 have the lowest rates of PrEP uptake among those indicated. And again, we see the racial ethnic disparities, with Black and African American people overall having the lowest levels of PrEP uptake, followed by Hispanic and Latino folks, and with white folks having the highest levels of PrEP uptake. What's going on with my slides? There we go. Okay, so now I'm going to talk a little bit about the goals and the study design. So our objective and aims and hypotheses were to test the efficacy of 3 disruptive innovation intervention modalities to support HIV prevention and related outcomes in a 4-arm factorial randomized controlled trial. So disruptive innovations means sort of simple, good enough interventions or technologies or services or products to meet the needs of most people. It comes out of the business world. Mary Jane Rotherham and I wrote about this with a lot of other colleagues as well. Things like ATM machines, $2 eyeglasses, minute clinics, and pharmacies are all examples of disruptive innovations. So in the context of HIV prevention interventions, we chose 3. So automated text messaging and monitoring, peer support in online social media spaces, and then telehealth coaching, or coaching that's strength-based telehealth delivered by near peers without these kind of complex manuals that has been the norm for evidence-based interventions and counseling modalities. So our aim was to evaluate the independent and synergistic effects of these 3 interventions by mixing the combination of them, and really with a focus on the primary HIV prevention choice outcomes, meaning PrEP, condoms, partners, or post-exposure prophylaxis. And then secondary outcomes for mental health, substance use, and housing and economic security. So our hypothesis was that the combination of all 3 of these interventions would have the largest impact, but we really hypothesized also that there could be effects for each one sort of separately. So we did community-based recruitment, not just clinic-based recruitment in LA and New Orleans through CBO and ASO partners, homeless youth servicing agencies like Covenant House, agencies serving post-incarcerated youth and youth who had been experiencing substance use disorder treatment, as well as on social media, and using active profiles, not passive banner ads, to reach out to people and invite to participate. And these efforts were led by our colleagues, Dr. Sung-Jae Lee at CHIPTS for Los Angeles, and Dr. Manny Ocasio at Tulane in New Orleans. So the youth we recruited had a lot of really challenging intersectional experiences. So mental health hospitalization, incarceration, and homelessness ranging from 25 to about 50% of lifetime experiences, and sort of intersecting with that, sex exchange, very common, lifetime, intimate partner violence, and suicide attempts. So a lot of sort of what we call structural risks and mental health challenges that are all sort of related. We recruited a diverse and inclusive participant sample with a range of ages starting on the left. Kind of highlight a few. There's a lot here. If you're interested, you can kind of focus in on things of your interest. But we also included about 12% transgender people, including trans masculine folks, and as well as gender diverse and non-binary people. The sexual orientations, kind of, I think, commensurate with young people these days, are quite diverse, with about 55% reporting gay or homosexual, same gender loving down, and then 28% bisexual, and then a range of pansexual, queer, and other identities. The majority of the participants were Black or Latino, almost 70%. Range of education levels, employment statuses, insurance statuses, and sexual sort of sexual behavior, sexual health and safety experiences, including a range of partner numbers. So being an NICHD funded study that really was focusing on adolescents and including younger adolescents and focusing on early prevention, intervention, and developmental trajectories, we did include people who maybe did not have a lot of what we would typically call HIV risk when they were enrolled. It's a 2-year follow-up study, so we anticipated people sort of transitioning into more frequent sexual behaviors, potentially more partners over time for some people. Okay, so we did include originally cisgender female and heterosexual male participants who were at risk for a variety of factors. But over time and with funding changes, we really honed in on the sexual and gender minority youth for the primary sample for this study. We enrolled about 1,000 and followed about 900 after baseline and randomized to 4 different arms. AMMI is this automated text messaging and monitoring. And then we added on to AMMI, which everybody received as kind of like our ethically minimum standard for providing some intervention to vulnerable youth. We added a peer support, another arm that had coaching, and then the combination of all 3, coaching plus peer support plus text messaging. And we did assessments every 4 months over 2 years that included rapid HIV tests, urine drug screens, and annual rapid PCR tests for rectal STIs unless indicated by symptoms. So we originally did oral, pharyngeal, and urethral STI testing, but it was pretty expensive, so we had to scale it back. But if people experienced symptoms or reported symptoms, we would do testing at any time. And then also provided same-day STI treatment for the bacterial STIs. Okay, I'll talk a little bit about PrEP barriers and then our intervention impacts. So just highlighted on the right there that the baseline sample, 11% were currently using PrEP and 18% had used PrEP in the lifetime, which is pretty similar to those national estimates in 2019 of about 16% of youth. This study was conducted, or we enrolled participants from May of 2017 through October of 2019, and then followed for 2 years. So we were really running from the 2017 to the 2021, end of 2021. All right, so the barriers to PrEP initiation that folks reported were primarily at baseline, I don't think I need it, was most frequent at about 2/3 or 37%. Now that increased over time, which is this top blue line in the slide. So over time, people's other barriers kind of declined, but the folks that opted not to use PrEP really kind of were siding on this idea that it wasn't really for them. But the other barriers kind of at around the 20% level were concerns about side effects, cost insurance, or difficulty accessing. And then the kind of next lowest tier of barriers, around 10% of people, were things like schedule conflicts, meaning it would be difficult for them to take the medication, or discomfort talking to doctors, or lack of social support. But those last two really declined after baseline over time. Okay, so we're doing some analyses we're in the midst of right now with a grad student that's just kind of looking at these factors associated with this. I don't think I need PrEP. So folks that reported not thinking they need PrEP were more likely to be Black or white, gender diverse or trans masculine, or experience incarceration in their lifetime. And those that said, I don't think I need it less frequently, meaning they had higher perceived PrEP need, were those who had lifetime suicide experiences, attempts, previous post-exposure prophylaxis use, more sexual partners, and hazardous alcohol use, basically sort of binge drinking. But daily adherence for PrEP was not the primary challenge for our participants. Overall self-reported adherence, which was what we were able to measure, was very high. Over 90% reporting taking PrEP daily or almost every day for those who were taking PrEP. And we had very little use of sort of 211 or episodic dosing. We did do some educational kind of campaigns around that when that was announced and when PrEP was approved for younger adolescents in 2019. Okay, so now the intervention effects. All right, so again, we focused on these three adaptable and flexible interventions, and I'll talk more about this kind of intervention journey later and kind of dive into the details of how we came up to this approach and why we think it's important. So these were our RCT results for PrEP use. So the left figure is the raw proportions, or the percentages of people in our sample that we followed over time, and the right plot parallels that, but that's estimated probabilities based on some fancy statistical analyses that Dr. Kamalata and team conducted that adjust for some differences between the groups, as well as loss to follow-up over time and things like that. So the big punchline here is the purple lines are the combined intervention of the text messaging plus peer support plus the coaching. Now, looking at the left, what we see is that current PrEP use at baseline was kind of in that 11% range, as we saw in the previous slide, across all the groups, and notably increased across all four of those intervention groups: text messaging alone, texting plus coaching, texting plus peer support, and then all three, from baseline to 4 months. Again, from about 11% to maybe about 15, 16%, kind of matching the national average that the CDC estimates. Now, after the 4 months, the PrEP use kind of declines or stabilizes among all the other groups except for the combined intervention of peer support plus coaching, which continues to increase until we are reaching nearly 24% of people in that combined intervention group using PrEP by the 12-month follow-up. There's some dips and declines. And then the bottom three lines showing the other three groups are pretty similar over time. And those ups and downs and declines, and on the right side, you kind of see these waves that are estimated, probably has a lot to do with COVID, because COVID hit right in the middle, close to the middle of our study as we were doing our follow-up assessments were really starting. And our youth advisory boards and others, our community partner colleagues reported, and our youth reported difficulties accessing PrEP during that period, but also lower need for PrEP because people kind of went into lockdown, and many people had lower numbers of sexual partners or just completely abstained from sex for periods of time. And then we see this kind of uptick in PrEP use again towards the end of the study as the COVID lockdowns kind of declined. All right, so secondary outcomes. So we had a range of secondary outcomes, but none of them were impacted in our overall intervention effect analyses. Nor did we see any changes in condom use. I'm just going to go back to the slide for a minute. In condom use, PrEP use, which was pretty rare, or partner numbers. And basically what our data is showing us is that people that were using condoms and or had lower numbers of partners or other kinds of partner strategies like testing and monogamy and things like that didn't opt for PrEP use. PrEP use was more likely to be adopted by people that had higher numbers of sexual partners, had lower consistency in condom use, had more experiences with STIs, and so forth. So, basically folks who were using other methods continued with those, and folks that had a difficult time with those methods were more likely to adopt PrEP. Now, in terms of the secondary outcomes, what we did see was an intervention effect on services use. So let's see, on the left side, we see the 4 arms that I just showed before. And so this is a little counterintuitive, but we see declines in service use over time, which is something we would expect and actually hope to see, because as young people are engaged in our study and getting referrals and also engaged in their CBOs and ASO partners, they're hopefully getting some of their needs met over time. But we know that it's very challenging to stay engaged and persistent in services. And, EHE has a big focus on keeping people engaged, not only in HIV care and prevention, but also ancillary services. So that's what this was measuring. So on the right side, and I'll come back to the left side in a second. On the right side, we see the most common services people were using were things like basic daily survival food, housing, clothing, and then kind of moving into this middle group of case management, transportation, mental health, employment, and healthcare counseling. And then kind of a bottom cluster of I think a little more tailored or specific needs for different groups of youth, like hormone therapy for the trans and gender diverse youth, healthcare navigation, substance abuse treatment for those working on that area, post-incarceration or parole, child care services, and so on. And so when we looked at all of these services together, what we see on the left side again is that people in the text messaging and the text messaging plus peer support had much greater sort of decreasing rate in services use compared to the 2 coaching arms. The AMMI texting plus coaching, meaning that green line and the purple line, actually those interventions helped, and particularly it's the coaching, helped participants, youth, stay engaged in their services, like help them to stay persistent, because it's a big hassle and we'll talk more about the interventions in a minute, but to set the goals, to be accountable to themselves, to have the support of the coach with navigation and follow-up. And then that number at the bottom is just the odds ratio. So it was a 1.23 odds ratio compared to the text messaging alone. And that was the same exact odds ratio and confidence interval for both of those 2 arms, the coaching and the coaching plus peer support. Now, we are looking at subgroup analyses currently to see if youth that had higher acuity of, for example, mental health symptoms at baseline may have benefited from the intervention in some way, or substance use, but in the overall effects not. But in these services, basically, there's a great diversity in the services that folks were needing based on their individual needs. I have chat stuff I should be looking at here. There we go. Okay. All right, so how did we get here? So I'm going to tell a little story about how we got to these interventions, and then I'll kind of go into how the interventions function in a bit more detail. So I'm calling this the CHIPS family tree of evidence-based interventions for youth. And we really started, these were interventions by Mary Jane Rothram Borst, but many, many others all over the country, collaborators and partners, and big kind of networks worked on these. So there was Street Smart in the late 80s and early 90s. There was Project Light. These were small group interventions, and I started working on this stuff with Project Light in around 94, 95 as it was winding down. And then there were interventions developed for youth living with HIV, what we called secondary prevention trials, because at the time this was pre-antiretroviral treatment availability. So there was TLC, or Together Learning Choices, which was a small group format intervention. And we had big challenges, as I'm sure many of you frontline folks know, in getting groups together. And so we then adapted TLC into CLEAR, which was one-on-one delivery and also telephone delivery. These all had really good evidence for intervention effects on a range of outcomes, not just condom use at the time, but quality of life, mental health, and substance use. They were also very intensive. They had something like 30 sessions, 3 modules of 30 sessions, 10 sessions each, or 18 sessions when we got to CLEAR. We then worked with CDC on replication and diffusion efforts through the REP and DEBI programs, for folks that remember those, the diffusion of evidence-based interventions. So Street Smart was replicated and is still actually being implemented in Uganda and other places around the world. TLC was replicated in the training support, but it never really got uptake because of the small group format. It was really challenging and is even more challenging now, although potentially with online and Zoom, there's maybe a new opportunity for group interventions again, hard to say. And then for CLEAR is really where we had the implementation success. So from 2005 to 2007, we worked with the prevention training centers. The intervention was adapted and incorporated probably maybe one of the first kind of ideas of status neutral. So we adapted the intervention to be applicable to high-risk HIV negative folks, as well as people living with HIV. It was the most popular DEBI program per the CDC. Over 900 providers were trained across more than 300 agencies. And then there's some data I got around 2020 is that over 25 agencies had been trained. And in fact, the prevention training centers are still training on CLEAR. We still get requests from people that want to implement CLEAR. It will be, I think, anybody who has CDC funding can request free training through the PTCs until the PTCs are recompeted, I believe, this year in November, and we'll see what the new training and support things look like. Okay, so what did CLEAR look like? Well, here's the client experience flow from the CLEAR implementation training slides. So you recruit clients, you screen them, you find out if they're eligible. Then there are these 5 core skill sessions. And it says assessment, and there's some core skill building in these, like goal setting and problem solving and relaxation and so on. And there are some applications to behaviors that people get to choose in those. And then once people make it through those 5 sessions, they can pick a module of a tailored module. We didn't do this in the original trial. This was part of the adaptation process. Modules focusing on stigma or disclosure, substance use, adherence, whatever people want to choose to work on. But the reality is very few people get past core skills session 1, getting to know each other. These interventions are manualized. They're very difficult to actually implement in practice. We were hearing this when we were helping to train people. Our CDC colleagues kind of shared with us their disappointment. And when PrEP came along, everybody was really excited to move to high impact prevention, biomedical prevention. So what's the challenge here? It's a challenge across evidence-based kind of counseling intervention. And it's this idea of scripted manuals. And so it's like, how will I ever master all these manualized, interventions, even if they're brief 2-session interventions, which a lot of the field had moved to in the last 10, 15, 20 years. If only we would understand like kind of the basic elements, maybe we could apply those in practice. And we think that's actually what a lot of people do when we talk to them about how they implemented CLEAR. They trained on it. Maybe they did the first session, and then they maybe just kind of take some of the bits and pieces and do it in their daily practice. So what did we want to do? We wanted a simple, good enough, flexible, tailorable approach to evidence-based interventions. So here's a cartoon. I need a simple door, nothing fancy, just in and out, nobody gets hurt. Maybe this is something Scott's our resident cartoonist may have. So there's all these common theories and functions and principles and practices and elements, and a lot of times intervention developers like to emphasize the differences or the unique aspects of their interventions. It's what you kind of have to do to get funding and to get funding to do the trials, to develop them. You have to say what's different. And then if you want to get sort of when you're marketing for people to adopt in the real world, you want to say what's special about your intervention. But really, they're all doing the same thing and talking about it in different languages, in our opinion. So here we are back to our 3 adaptable, flexible interventions: text messaging, online peer support, and coaching. All right, so the text messaging. So these were adapted. This approach was adapted really from a lot of work with Kathy Reback on Project Tech Support and others, but others have been doing text messaging interventions. And we adapted a bunch of text message libraries with community advisory boards, youth advisory boards, as well as our staff and our co-investigators. So we sent out a daily message on healthcare, wellness, and medication or PrEP adherence for those that were using ARTs. Now, I'm talking about our study with HIV negative young people, but we applied these same interventions to 2 other protocols with youth with acute HIV infection and youth with established HIV infection in 2 other studies. And then on the weekends, we sent messages on sexual health and substance use, and that was based on our youth advisory board feedback, that's when those messages would be most relevant. So people received up to 5 messages, text messages a day. And on the right, you kind of see some examples of these brief little prompts. They're like little reminders, motivational prompts, in some cases, resources, links to websites and other resources. The slide on the left here shows the 3 studies I mentioned. You can kind of, but the bottom line is, it's the total proportion of people reporting that they were receiving the text messages. On the far left, about 75% of the people assigned received messages, and the majority of those read all or most of the messages. That's those bars on the right. And then the next slide on the right, or that graph on the right, kind of shows the ratings of acceptability, how much people liked those messages on a 5-point scale over time. We also had a 7-item check-in survey that was sent by text message or email on a weekly basis, where we asked about STI symptoms, potential acute HIV symptoms, depression, substance use, condomless sex, housing and food insecurity, and medication adherence. This was partly this idea of self-monitoring. So people are reflecting on what their week was like. In ideal situations, we would also be following up on the responses to these things with referrals. That was challenging. There's a lot of information coming in, but that's kind of the goal. People were incentivized $1 for responding to each survey, but actually our advisors, our youth advisory board, and our participants said it really wasn't much of an incentive. Either you were going to do it or you weren't. And about 50% responded to the surveys over time, which actually was kind of surprising. All right, so now moving to the peer support and online. And let me see, if you have questions, you can put them in the chat. Oh, thanks, Gabe, for sending more information on Dr. Rebatt's work. There was a question about eligibility. So eligibility was pretty inclusive and broad. Basically, anybody that reported PrEP use, condomless anal sex in the past year, or other combinations of factors like substance use, or just reporting actually being sexual gender minority youth pretty much would get people into the study. Again, the part of the reason was that is we weren't necessarily going for necessarily the highest risk folks. We were kind of going for a more real world type situation, as well as one where we could do early intervention and prevention. All right, so peer support. So the idea of this was adapted from other work that colleagues had done around online peer support. Sean Young, but many others have attempted this. So it's a private, anonymous online space, so not on Facebook, with some lessons we learned from our SPINS initiatives. Young people were provided $10 incentives to post 3 times each week to be peer supporters to each other. And our study coaches moderated and kind of were like sort of secret shopper, mystery lurkers. They eventually scaled back their role on the peer support boards. We used Moot because of some IRB issues with privacy controls and direct messaging and things like that. But if we were to do this now, we'd probably use something like Discord, which is where a lot of people are hanging out these days. Okay, so what kinds of conversations happen on the peer support boards, and what's the point? Well, first of all, it's about peer norming. And so this on the right is an example of a discussion about regular HIV testing and STI testing, and how people are kind of like, how often do you get tested? Well, I haven't been testing. I test every 3 or 4 months. But I think the most important examples around PrEP, the PrEP conversations that were happening. There's a lot of mistrust. A lot of people in the study, our youth advisors said, don't be PrEP pushers, right? Like we really went with the choice, but PrEP was still really important. So here's the conversation. I don't know whether I should take my PrEP pills or not because my friends tell me that it's not worth taking them because of the side effects and the fact that they're using us as guinea pigs. So I don't know what to do. Should I take them or should I stop? And then, have you talked with your doctor? I'm planning on starting, but waiting until I can get a reliable supply. So there's a little bit of barrier there, but I'm nervous about the side effects and may stop if it's too much. And then somebody else chimes in and says, I have multiple friends using PrEP who have never experienced side effects. This pill is not using people as test subjects. It's here to help prevent the spread of HIV. If you're having sex, I definitely recommend. And then people say, talk to your doctor or someone at the LGBT center. PrEP is changing and saving lives, in my opinion. I've never experienced any side effects and I've been taking it for 3 years. So even something as simple as that can go a long way. All right. So our coaching, our most intensive and costly intervention approach, is based on this idea of strengths-based case management. So we assess and build on youth's strengths and resilience. It's client-centered and focuses on the hierarchy of needs, so housing and employment and relationships, mental health, substance use. There are near-peer paraprofessionals, so we actually recruited and hired people who had worked as frontline HIV prevention workers, as peer educators, outreach workers, PrEP navigators, and so on, and we trained them in evidence-based practices. We provided support ongoing for 2 years during the follow-up period of the study to address needs and developmental transitions, crises, or to just be there when people who initially said, I'm not interested, were like, you know what, I am interested. And this is really designed for diffusion in the ways that I had talked about before. And flexible in delivery, telephone, text message, in person. I'll talk a little bit more about that. So our core elements were these practice elements. We assessed the strengths. This pyramid sort of shows the hierarchy of needs, and that this understanding or this idea that you really can't focus on sexual health unless you've addressed like food and housing insecurity, like and other syndemic factors. And then we focus a lot on linkage and navigation, but really with goal setting, problem solving, and follow-up. So it's not just a passive referral. It's a warm handoff. It's a let's get on the phone together, or a follow-up to say, hey, how did it go when you contacted that, that housing services navigator or the PrEP navigator in your community? And then there are adaptable or flexible pieces, which is who's delivering the intervention, the format, the period of follow-up, and the kind of ongoing support for the seasons of risk. This just shows that the overwhelming majority of successful contacts that our coaches had, was by text messaging or chats, followed by phone. We did allow some intervention. I will talk about the caseload. That's a great question. So we had, I think at peak, about 10 coaches across LA and New Orleans. They could handle a caseload of about 60 people, which is still pretty limiting, but we have some ideas about how we can improve or manage that. All right, so we didn't use manuals. We used like basically one-page tip sheets like this from colleagues at that do other adolescent and youth evidence-based mental health treatments. And then our staff basically turned these sort of tip sheets of these are the things you got to do into little short slide decks for our kind of team-based ongoing routine training and supervision. Now, which practice elements did we use and why? Well, this was I love this table. It's from a review. So our group did a bunch of reviews of manuals of the evidence-based interventions for HIV prevention for youth. This is from another group. They examined evidence-based intervention for adolescent prevention programs across a range of areas: substance use, life skills, sexual health, violence. And you can see number one at the top is problem solving. And then there's a bunch of other things that kind of go down: assertiveness or goal setting, social skills, coping. But really, problem solving is super critical and super key. So what else did we do? We had a mobile app, but it wasn't for our youth. It was for our case managers or for our coaches and for our interviewing staff. And so that was used for sort of monitoring and evaluation in real time, as well as for supervision. And so these are the practice elements by one of our coaches. And we can see that there was really, we had a lot of focus and emphasis on engagement as well as praise. And we had youth tell us that they'd never experienced receiving praise for anything they'd ever done in their life, but really goal setting, problem solving, and positive alternatives to potentially unhealthy or risky situations. And then there's a whole bunch of other little evidence-based practice elements that get more specific, like referrals or relaxation techniques or building social support, and then all the way down to things like triggers for substance use and so on. Now, we applied those practice elements to all these different domains of our outcomes. So daily living being the most common, and then social relationships within which, sexual behaviors are embedded, and then sexual behaviors, mental health, and PrEP. So the idea is modular. You take these skills or elements and you apply them to youth's priorities and needs. So our big picture here is that we believe that frontline prevention workers can adapt evidence-based practices to their local context and their individual clients. So we work on the foundational skills of the evidence-based practice evidence. There's content tailoring that can happen around all different ways. And the local adaptation doesn't need to be done by people. It can by experts or whatever you want to call us. The experts of the local thing are the people out on the front lines. You're the experts. Assuming some of you are in the audience here, I hope. All right, so we started with a strengths assessment where it's like kind of a get to know you interview. That's a semi-structured interview. And we documented kind of where folks were, but really focused on their strengths. Here people talk about resilience that we presented previously about their mental health challenges, but also how overcoming their mental health challenges really helped them to be resilient. These are the different domains of the strengths assessment: daily living, relationships, health, healthcare, mental health, ending on sexual health, not starting with. And then the big focus after the strengths assessment was goal setting. So youth setting 3 goals. Always one has to be sexual health, and coaches supporting them. And really what participants talk about is a lot of help with accountability to their own goals, and then coaches following up to check in, and helping problem solve when goals aren't met, resetting goals, navigating to indicated services, and so on. These are just some examples of a range of goals. So getting housing, opening a bank account, applying for jobs, obtaining naturalization certificates, relationship goals, and then, of course, the sexual health goals, wanting PrEP before transferring to a new university, as one example. Our youth advisory board has given us a lot of really great feedback. One talked about her coaching experience. I really needed someone to help me be accountable to myself at that time of my life, and my coach was my rock for the first 2 years of being homeless. I felt like everybody who was important to me disappeared in that time. This person had come out and was rejected by, their family. A lot of discussions around PrEP, of course. We had a discussion around inclusion of transmasculine and gender diverse youth and community inclusion. Yeah, so I'm just about to wrap up and we can move to questions and answers. So PrEP use. So we had modest increases in PrEP use in our combined intervention. And that was a combination, to Dr. Lee's question in the chat, of new and continued use over 12 to 20 months. So there were people that went off PrEP and came back on PrEP. There were people that were starting for the first time. This was not a PrEP continuation or persistence intervention or study anyway. So we were looking at the overall kind of like population kind of level inference impacts. But is it enough to bend the curve? Well, according to some modeling studies, 25% of folks taking PrEP could be enough to bend the curve, in addition to other interventions. So how do these interventions function? Well, peer support handles the social norming, the sharing of experiences, and the demystification. The coaching focuses on goal setting, navigation, and follow-up. The text messaging provides the nudges and the reminders. Yeah, they can be annoying. And just as a note there, we had very little emphasis on PrEP use in those text messages. Maybe like 10 messages out of like 1,000 messages or 800 messages that people may have received. And so our results support this kind of like need for this hypothesized synergistic effect of these different functions implemented in these sort of simple, easy to implement and adaptable ways. And then we also had our effect on service utilization. So some conclusions: we need to address youth diverse needs and priorities with complementary interventions to support HIV prevention, and rapidly adaptable and implementable disruptive innovation interventions can be efficacious. We don't need crazy manuals with fidelity to scripts and other things that we're often told we have to do to maintain the effectiveness. What we really need is ongoing monitoring and evaluation to know if our interventions are working. So we're in progress with cost effectiveness analyses, as treated or post hoc analyses, like who did the interventions work for or not? Were there outcomes for subgroups of people that had higher mental health acuity or higher substance use? And then we're also working on intervention innovations. So chatbots is an area that Dr. Kamalata is leading, and with collaboration with some of our other colleagues, to make our text messaging more interactive and to support the scalability of coaching. Because what our coaches reported with the question about the caseloads is it's very challenging to manage a caseload of 60 people or more, for the contacts, the hey, how are you doing? The hey, let's schedule some time to talk. It's really difficult to keep up. And so automating some of that stuff could help with the bandwidth issues to carry larger caseloads, or at least to ensure consistency of follow-up and check-ins. And then also implementation with real-world folks in real-world organizations. potentially working with PrEP navigators or peer counselors, outreach workers, or maybe the model is going direct to youth with a kind of like centralized program, since it's kind of all remote anyway. But we'd still need to work with organizations for enrolling or recruiting youth to participate in these things. So to that point, we have hopefully good news that a CHIPS EHE supplement is about to be funded to do some implementation preparation. We'll do some mixed methods, data collection and networking, intervention package update, some intervention strategy development to prepare for a type 2 hybrid implementation effectiveness trial with real-world organizations. So our partners in this supplement as proposed are Friends Research Institute and Community Center, True Revolution and Riverside, and Loma Linda University Health Institute for Community Partnerships, which is a big community health worker training program. And they have folks that are doing like PrEP navigation in emergency rooms and now in pharmacies, work led by our colleague, Alex Dubov down there at Loma Linda. So these kind of represent different kinds of community organization as well as medical setting organizations, but we're definitely interested in more collaboration with more partners. So let us know. Okay, so I'm going to conclude with a thank you to more people than we can possibly name. These are some photos of all the folks that contributed over many years. It's a massive undertaking, a huge effort. It was, I think, 7 or more years of our lives with a lot of passion and effort going into it. And with that, I will conclude and say thank you and open it up for questions and invite collaboration. You can email me if you're interested in talking more about our future implementation work. And I'm going to scroll the chat. I think Scott has maybe prepared some or gathered some questions.
Yeah, thanks, Dallas. Well, we can tell it was a really good talk and there's a lot of interest because we have a lot of questions. So I want to, Michael Hamer, I think Dr. Swendeman answered your questions, but I just want to acknowledge them. If you have any further, please drop it in the chat. I'm going to go down to a question from Paula Tavro. What was the difference in costs of the 3 interventions?
Well, we're still working on that. So it's a great question. It's one of our aims. Yeah, so the cost for text messaging is really cheap. I think it's probably like less than 5 cents a day per person. I mean, even if you multiply that over, 300 days a year or something, it's relatively inexpensive. Peer support is also relatively inexpensive. We paid people. So even if you don't, we paid people $150, $160 to kind of be peer supporters to each other. I think for young people in particularly, it's important. And I think helping other people helps yourself. So that could be, possibly cost effective. Now, coaching is where the real, expense is, right? Those are full-time staff positions. We recognize that they're expensive. And we are, again, working on ways to try to use technology to enhance that. But we do believe that personal relationships and things like coaching are pretty essential. We don't believe that technology is going to replace things. We believe technology can enhance.
Great. I'm going to go down to a question from Marvin Vasquez. What did the preliminary assessment consist of and what makes a client ineligible?
Yeah, I mentioned the ineligibility previously. We had an initial 12-item, I think, screener that asked about, sex, drugs, STIs, homelessness, incarceration, structural risk factors in addition to behavioral factors. And then from there, actually the eligibility was pretty high. Our enrollment inclusion criteria were quite inclusive, at least initially. We narrowed that down, I mentioned later, based on work with our funders. Because it was an adolescent trial, also included very young people, 12 or 13, not very many, but certainly people that had not even really initiated sexual behaviors yet. It was pretty inclusive.
Thanks. I'm going to go down to a question from Dr. Sanjay Lee, who is also heavily involved in the project. I believe you answered a number of his questions, but this is a good one here that I think you touched on, but if you could elaborate a little bit more, and that is, how did let's see, lost my train. Oh, there we go. Just the variations in how coaching was delivered pre and post COVID.
Well, we were already doing telehealth pre-COVID, so we had designed it to be telehealth. And, using text messaging, we gave options for, video chat, things like that. So we were pretty well primed for the coaching and the interventions to just continue without too much interruption. Some participants and some coaches did prefer to meet occasionally in person, depending on if they had a service organization that they felt comfortable at and where there was space. A little more New Orleans. Also, New Orleans is a smaller town, so it's much easier to get around and to get to places. LA is so huge and spread out. In person was difficult. So we were able to pivot there pretty easily. The pivot to the other pieces of the study with COVID hitting were quite burdensome and traumatic for our assessments, because we were doing all of those in person, as Dr. Lee knows, including the rapid HIV test. We did try to do mail-based testing for folks. A lot of people did not prefer it. They wanted to come in, even during COVID, and get there, because we were providing rapid results and same-day treatment for the STI. So people wanted to come in and get their results, as well as get money and cash for the incentives for the study.
Great. Let's go down to another question. This one from Dr. Karen Nielsen, who is also one of the study PIs and heavily involved. She said, great talk. Can you comment on the HIV seroconversions in ATN 149?
Yeah, thanks, Karen. So I mentioned there are 3 other studies. So ATN 147, which Dr. Nielsen Karen led, was our study of youth with acute or undiagnosed HIV infection. And over the 2 years of follow-up in ATN 149 with our participants, we identified, I think, something like 31 or 33 seroconversions, so people who seroconverted. And then they were moved from our study, or from my study, 149, to Dr. Nielsen's study. I see her on video there. And then they were provided immediate linkage to treatment and were followed for the study that Karen led around immune function and response to early treatment. But I think what's important there is that if we do continue to engage youth, we can identify early stage and acute HIV infections and get people in the treatment as soon as possible. And that's another great sort of benefit of this ongoing approach.
Great. Thanks, Dallas. I see we're almost at time. Michael sent me a message on what text messaging platform was used, and I direct responded to him. So I realized, for the benefit of the group, I'll just mention we used Twilio, and Demagi's ComCare system was used for data management, so there was an integration with that. Dallas, if I could throw in my own question, just getting back to the plot showing the PrEP improvement in the combined peer support plus coaching arm. Just talk a little bit about, on your hypotheses, why the coaching plus peer support together did better than coaching or peer support alone. And actually, even in relation to, they were very close to AMMI. So it really was a synergistic effect of the two that made a difference.
Yeah. Well, it's kind of my concluding slide on those complementary functions, right? The peer support provided, and not everybody participated in all these interventions,
right.
But people that needed to did, and it seems to have had an effect. So peer support provides that kind of authoritative youth voice, peer voice, about things like their PrEP experiences and kind of demystifying that. There were more PrEP conversations talking about where they would get their PrEP services or what their experiences were, how it wasn't traumatic, talking to their doctor, and things like that. The one limitation, a major limitation that was, challenging for us with this study is we didn't have a true standard care control arm. So everybody got some intervention, right? Including the text message. The text messaging, 5 text messages a day is not a light intervention. I mean, it's a cheap intervention, but it's not light touch. And other studies like Kathy Reback's have shown that at least among super high risk groups, text messaging alone can have effects on reducing HIV use behaviors, and certainly on improving like adherence. Those daily reminders for adherence reminders are pretty critical. I mean, on the right side, you do see AMMI kind of on the pictures, kind of shows a little bit lower. If we had a control group that didn't have any text messaging at all, I do wonder what these effects would look like. We just couldn't do it ethically because we needed to provide some kind of intervention with some evidence of effects for our vulnerable young people. Scott, did you have anything else you wanted to share from your insights? Maybe you had another answer to the question.
Kind of right along the lines too, what I was thinking. It's nice to hypothesize to prompt future research.
Yeah.
So, I think we're at time, right, Dami? I see from the thank you there for attending.
Yeah, feel free to wrap up.
Okay, well, that's it. Thank you so much, everyone. Appreciate your time. Let us know if you're interested in talking more and potentially partnering on hopefully our newly funded research, if not now, then in the coming months.
Right. Thanks again, Dallas.
Thank you.